According to the World Health Organization, Kenya is one of the 22 high-burden TB countries that together account for more than 80% of the world's TB cases. The estimated deaths due to TB make it to the fourth leading cause of mortality in the country. Case detection has been enhanced through community engagement, inclusion of the private sector, intensified case finding, pro-poor enablers such as nutritional support, TB/HIV collaborative activities, and an increased focus on identifying TB in children. The Kenya government has nurtured strong partnerships at national and county levels with the donors, international and national NGOs, civil society organizations, and technical partners through its interagency coordinating committees, ICCs. Kenya was the first African country in 2008 to attain the World Health Organization targets of detecting 70% of TB cases and treating 85% of these cases successfully. In 2014, 90,000 TB cases were reported. However, it is estimated that there are about 20,000 missing TB cases that go undetected and untreated. These missing cases likely contribute to the ongoing transmission of TB in communities and thus hinder the nation's efforts to attain zero TB infections and zero death. Other factors that have contributed to this large TB disease burden include poverty and social deprivation, mushrooming of informal settlements in the peri-urban, congestion in prisons, other congregate settings with limited access to general health services. Until 2017, the true burden of tuberculosis in Kenya has remained unknown, with the last TB prevalence survey being conducted before independence in 1958 to 1959. This survey provides a better estimate of the burden of TB and assesses the associated health-seeking behavior of TB patients and those reporting TB symptoms. These findings will be used to inform country planning and policy formulation to end tuberculosis. Ananda Marga Universal Relief Team, AMURT, is a local implementing partner for Global Fund Tuberculosis Project implemented by AMREF Health Africa as a principal recipient.
Ananda Marga Universal Relief Team, AMURT, was founded in India in 1965 by Sri Prabhat Ranjan Sarkar. We were doing the relief projects for the humanitarians. In Kenya, we are working in 11 counties, like 150,000 direct beneficiaries we are serving per year. More interestingly, these TB programs comes in Samburu and Marsabit. Global Fund came in the right times, and then we took that advantage.
AMURT got an opportunity to work with AMREF Health Africa as a sub-recipient in the Global Fund project focusing on TB prevention and management. So we started a partnership with AMREF Health Africa in the Global Fund project in Samburu County.
The project started in 2016 in Samburu County and thereafter expanded to Marsabit and Kilifi counties. Actual activities carried out by AMURT are contact tracing of smear-positive patients, TB defaulters tracing and reinitiating treatment and adherence, screening of children under 5, health education and screening in prisons, and integrated outreaches in every sub-county. In Samburu, the project operates in Samburu Central, North, and East sub-counties covering 35 health facilities, 15 in Samburu Central, 12 in Samburu North, and 8 in Samburu East sub-county.
And I can say maybe thank you to the management of AMURT and the staff here in TB project. They are really doing the best.
In Marsabit County, AMURT project activities are in 4 sub-counties, that is, Chalbi, Saku, Moyale, and Laisamis, with a total of 34 facilities supported by the project.
Through the partners, that is AMURT and AMREF. We actually thank AMREF because they have entrusted us with this work. They are funding us fully because we are going to the community at all the time that we are required.
In Kilifi County, AMURT are in 7 sub-counties supported by the Global Fund New Funding Model TB project with a total of 103 facilities.
The cases are on the increase, the reporting is on the increase, the CHVs are motivated well, and we are able to find the missing cases, we are able to find the lost to follow-up cases.
We were given a target of 1,578 adults to find and check the sputum, and the positives are treated. And out of that, I can report that we have been able to achieve 93% of that target. That is 1,479. That is as at December 2017. The other key area of intervention was in contact tracing for children under the age of 5. And here we also had a target of 145 as AMURT, and we have been able to reach 124 children under the age of 5. That is an 86% performance in the year 2017. Target that we had for TB interrupters was 153. We surpassed the targets by 46% because we were able to get 224 TB interrupters and put them into treatment and ensure that they are not sick.
Some of the challenges AMURT encounters in these counties is poor road networks. This is hampering movement of goods and service to and from the counties. Other roads are usually impassable during rainy season, thus hampering delivery of essential services. AMURT supports the community TB-based care at the community level through community health volunteers, CHVs, community health extension workers, CHEWs, and lead CHVs.
When we get a patient who is sputum positive, a father, a mother, or whoever, we try to look for the contacts. We get all those who live in that household, especially those who are under 5 because they are not immune. So we know they can get TB very easily. And so the community health worker visits the sputum positive house and makes sure she brings all the children to the clinic, and we examine them, we look at them, and those who have TB we treat. Those who don't have, we give isoniazid preventive therapy.
In line with the new constitution, the devolution of government functions and resources to the 47 counties is swiftly changing the mode of operations for the health sector, including the management of TB.
She started the first-line treatment when she was diagnosed with TB, pulmonary TB, around 2013. But due to the issue of pastoral life, she has been migrating on and off. We started the treatment for 20 months, that is 8 months of intensive and 12 months of continuation. So we had to give her injection daily for 8 good months. And then the patient refused completely to take treatment. She was chasing us, we were coming to her home, and at that time the patient was very sick. She could not walk. She was just lying down. This year, February, we started her again on treatment. We did the investigation. Still the smears were positive. The microscopy was positive. Gene expert was still positive. So we did all the investigation. She has completed the injection, 8 months of injection. Our investigations are very good because now the smears are negative. We are happy. We did culture, they are negative. Almost 2 times now they are negative. So she has to continue with the 20 months of treatment, which will end next year in October. So we can see even the community around here, they also needed a lot of health education. So with the help of our nurses, we tried to talk to them. We gave them health education about TB. And all the time, we have been screening the children who are around here. And I'm very happy because she's also getting some support from the AMREF through the TB program of around 6,000 shillings per month. That amount means a lot in a very poor mother like her.
We initiated the baby for TB treatment because she had been diagnosed with TB meningitis. We started the baby on treatment. The mother actually collected treatment for like a month. Then actually she defaulted from the clinic. By the use of the AMURT, with the project of defaulter tracing and contact tracing, we were able to trace the baby actually back. We started actually the treatment afresh after getting the patient back. The patient was actually at a witch doctor for those 8 months. When she came back, the baby was in a critical condition. Currently, as we speak, the baby is cured of TB. What you can see, she's not fully recovered because the lower limbs are still weak. But actually, if you compare the situation she was before and now, the baby is well and is stable.